discussed. I would like to present it as
Dr. Sarin is an alumni of Government Medical College, Thiruvananthapuram, and he did his MD General Medicine from Govt Medical College and joined Pariyar Medical College in 2010 and is working in Department of Medicine in the institution till date. Since 2019, he is also working with additional responsibility as RMO at Government Medical College, Kannur. Dr. Sarin is undergoing in diabetology and has published original articles in 7 national and international journals. He has also written health-related articles in popular science journals and books. He is interested in biomedical research and biostatistics. Dr. Sarin also interested in public health activities and was involved in the state and district health subcommittee of Kerala Shastra Sahitya Parishad. With this words, I invite Dr. Sarin for the speech.
Monkey Pox dita
Respected President and Secretary of IMI Kannur, respected senior faculty, senior members of IMI, and my dear colleagues. First of all, I would like to thank my own IMI branch for giving me this opportunity to present a scientific presentation before you. And this topic is the most discussed topic maybe in last 1 month or so, as this is the new emerging disease, even though it is not a new disease, but in 2022 it is a new disease that has occurred in multiple countries all over the world, and it has reached the shores of Kerala. So I would like to present this topic regarding monkeypox, which is the new visitor to the emerging diseases gamut before you. So as I have already said, there are 2 confirmed cases of monkeypox in our state till date, and even though the disease is there since 50 years in the world, affecting human being. Now in the 2022, the particular thing is that it has affected almost many non-endemic. Till now, there were some group of disease, especially African countries, where monkeypox were more common. But now, this year, the peculiarity is that it has affected many non-endemic countries, with total number of confirmed cases reaching near 3,500. As June 22, the count was 3,430. In Kerala, now there are 2 confirmed cases, and both are Gulf returnees, especially from Dubai, and they are being currently isolated and treated. What is monkeypox? Monkeypox, as the name suggests, is caused by monkeypox virus, which comes under genus orthopox virus in the family Poxviridae. And it is a double-stranded DNA virus with almost 2 lakh base pairs. So it is comparatively large DNA containing virus. And it was first isolated from an animal in 1958 in a research lab from a crab-eating macaque, which is a type of monkey, and hence the name monkeypox was given to this disease. Later in 1970, the first human case was reported in Democratic Republic of Congo in a 9-month-old boy. Since then, in African countries, especially in West and Central African countries, there were every year some cases of monkeypox. But by 2003, outside Africa, first case arose in United States of America. And now in 2022, it has spread to many other countries too. There are two strains identified. There are two strains, and one is known as Central African or Congo Basin strain. Clad, it is known as, that is genetic. It arose from one genetic family. And second, second strain is West African clad. So where do we get monkeypox from? The question, it is obvious answer is monkeys. But the monkey is here is not that satisfied with that answer. He is looking annoyed. Why? So coming to the transmission, as I have already said, it is a zoonotic disease. It comes from animals to human being from a direct contact with blood, bodily fluids, cutaneous or mucosal lesions of infected animals. Apart from this direct contact, we can also acquire monkeypox by eating inadequately cooked meat and using other animal products of infected animals, which can cause a possible risk factor. When we inquire about the natural host of monkeypox, but it is not correctly known which animal is the natural host, and probability is that it is rodent. So that is why monkey is not that happy with the name monkeypox, because the cute looking rodent might be the actual host of this virus. But monkeypox infection was found in multiple wild animals, especially small mammals like rodents like rope squirrels, tree squirrels, Gambian pouch rat, dormice, etc., but also in different species of non-human primates or monkeys. Now, unlike some of the zoonotic disease, it can also transmit from human to human, and in human to human, close contact with respiratory secretions, skin lesion from infected person, or recently contaminated object, that is fomite, also can transmit this disease. Respiratory droplets transmission needs prolonged face-to-face contact. So only large droplets are known to be causing transmission usually, and it needs prolonged contact. Some literature say up to 3-hour contact is needed for a high risk transmission, and close quarters, that is within 6 feet from the patient. Transmission can also occur from mother to fetus, maybe through placenta or during and after birth due to contact. The one important thing is that close physical contact is the main important known mode of transmission. Regarding sexual transmission, whether it is transmitted as a classical STD or STD in a classical sense is unclear. But definitely there are clusters of disease where transmission had occurred between men having sex with men community in UK and some European countries. It has also been transmitted from sauna. Sauna means that steam bath and such areas in Spain. So whether the sexual transmission is due to the direct contact or it is a classical mode of sexual transmission is not clearly known. Now coming to the clinical features, incubation period of the disease is 6 to 13 days, the total range being 5 to 21 days range. So 21 days is the maximum incubation period expected. There are 2 or maybe 3 phases. First phase is invasion period, where initial first 5 days of the infection, where the patient will have fever, headache, lymphadenopathy, myalgia, asthenia, like in most of the viral diseases. But lymphadenopathy is a very important thing because lymphadenopathy is not seen in similar diseases like smallpox, chickenpox, measles, etc. In the initial period where monkeypox was first detected, it coexisted with smallpox, which was then a disease which was about to be eliminated. So we were in the struggle to eliminate smallpox, but monkeypox, which was very similar disease but having a very less severity of disease, was coexisting. So one important clinical finding, that is differentiating between monkeypox and other pox, especially smallpox, and now it is more importantly chickenpox, is lymphadenopathy. Monkeypox will classically have lymphadenopathy and others will not have. The second phase is skin eruption phase, where the classical eruptions or rash of the monkeypox occurs. It occurs 1 to 3 days of fever, and it mainly has a centrifugal like pattern. That is, it mainly affects the peripheries and then come to central. The most common area affected is face. So almost in 95% of cases, you will have face and palms and soles. That is also a typical feature that where we can distinguish with many of the pox like chicken pox, where palms and soles are not that affected. But here in monkeypox, 75% of the patient will have lesions in palms and soles. Oral mucosal lesion also is very high, 70%, but it can also occur in other areas like genitalia, conjunctiva, and sometimes rarely even in cornea. The number of lesions can be very few to thousands. So as you might know, there is a patient in Pariyaram. So he only has 15 to 20 lesions, but it can be thousands or hundreds of thousands of lesions, and it can coalesce together to form large lesions, and sometimes skin over the area may slough off. Lesions, one particular characteristic they say is that it is a monomorphic lesion. That is, the lesion at a particular time will be of a similar nature. But that is, in our patient, it is not so. It is polymorphic, pleomorphic. So multiple stages lesion are seen in our patient. So it might not be always true, but they say that classically you should have monomorphic lesions. So first they will have just macules, then it will progress to papules, and then vesicles, pustules, and later, as you can see in the picture here, it is a first one is the vesicle, then it becomes a pustule. Then you can see a small umbilication. That is a classical monkeypox lesion, umbilication at the central part of the pustule, and then that umbilication will ulcerate to produce a lesion, that is the fourth lesion, and then finally scabbing occurs and it will slough off. So that is the typical progression of the rash, and that is the picture of the rash. Now, majority of the monkeypox patient is self-limited disease. It subsides on its own by almost 2 to 4 weeks. But there can be secondary complications, like the skin lesions may have secondary skin infection. The patient can develop bronchopneumonia. Patient can go in for sepsis, encephalitis, infection of cornea, and blindness. The case fatality is also wide range, 0 to 11. There are multiple causes for fatality. Maybe the standard of treatment is important. More importantly, the comorbid illness. If the patient is having comorbid illness where patient becomes immunocompromised, then the severity of disease may increase. And one important thing is pre-existing smallpox vaccination. It has been found that smallpox vaccination has a protective effect. So in our generation here, the 45 plus is protected and less than 45 is not protected. So that is why they say that monkeypox is now incidence is increasing, because the smallpox vaccination immunity is waning on. And another important, but the most important thing that decides the case fatality is which strain is affecting the individual. I have already said there are 2 strains. One is Central African or Congo Basin strain, which is more transmissible and causing more severe disease. So it causes it increasing the transmissibility is high, and also the severity of the disease also is high than the West African clade. And now they say that this 2022 spreading is mainly by West African clade, where the case fatality is around 3%, whereas in Central African clade it is almost high as 6 to 11%. Now coming to diagnosis, as you all know, the important test or most important test is PCR test, polymerase chain reaction test, which is very high sensitivity, almost more than 99% sensitivity and accuracy. In the national guideline, it is said that you initially do a PCR, non-specific PCR for orthopox virus, which has multiple diseases like cowpox, buffalo pox, camel pox, monkey pox, and earlier smallpox, but now that disease is not there. And if it is negative, you need to investigate for other diseases, whereas if it is positive, then you need to do specific PCR for monkeypox. The sample can be mainly it is taken from the roof, or roof means the base of the lesion, or fluid from the vesicles and or pustules. Also, you can test the dry crusts also. The difference between COVID sample collection and this is that it doesn't need any transport medium. You can just store in the swab, collect the swab and store in a dry sterile container, maybe a culture bottle or something, and then pack triple packing, and it also should be stored during transportation in cold. There are other tests like serology, antibody test, antigen test, etc. But it is not recommended for diagnosis because there is cross-reactivity with other orthopox virus. And there is also the chance of false positivity can also occur if the patient has received a vaccinia-based vaccine, that is smallpox vaccine. Now, these are surveillance definition, which is I will just rush through, given in our national guideline. First one is suspected case. Whom do you say that the patient is a suspected case? He or she is the person which of any age presenting in a monkeypox non-endemic country like India with an unexplained acute rash. But he or she also should have one or more of the following signs like a headache, acute fever, lymphadenopathy, myalgia, backache, asthenia, etc. And the rash should not be explained by other clinical causes. Probable case, the same suspected case if has some epidemiological link to the monkeypox. Maybe he has direct epidemiological link with the monkeypox patient within 21 days of onset of symptom, or he had traveled to the monkeypox endemic country in 21 days, or he or she had multiple or anonymous sexual partners in 21 days before onset of symptoms, and has a positive result for serological assay. So even though serological assay in absence of smallpox vaccination can be other pox virus also, but you can consider him as a probable case and send for PCR. Confirmed case is the same suspected or probable case, but you should have positive PCR test. And another term is discarded case. You are highly suspecting a case, but your PCR is negative. Since it is very sensitive and accurate, you can, if it is negative, you can consider it is not monkeypox. Now coming to the management part, the main principle of management is patient isolation. Majority of the patient are not severe. It is self-limiting within 2 to 4 weeks. So the main thing is avoid spreading of this disease. Patient isolation is the first principle. Second one, second three points is related to symptomatic management of the patient. So that is the main mode of treatment. You should protect the compromised skin and mucous membrane, because in severely affected cases, I have already said coalesced lesion can produce exposed lot of raw part and skin may be lost over lot of areas. So secondary infection, etc. can come. So protection of compromised skin and mucous membrane should be done. Rehydration therapy and nutritional support is very important. And what symptom patient had, you should give a symptomatic treatment. And last and important thing is monitoring and treatment of complications. The first part is patient isolation. The patient should be isolated in a isolated room in a hospital or at home with separate ventilatory facility, ventilation, and good ventilation. That is, and patient should wear a triple layered mask. Skin lesions should be covered to maximum extent possible. So patients should be advised to wear a long sleeves and long pants to minimize the risk of contact with others, and isolation to be continued until all lesions are resolved and scabs have fallen off. So only very similar to chickenpox, when all the lesions are scabbed off, then only you consider it as non-infective. Now coming to the supportive management. Supportive management is mainly dealing with alleviation of symptom, management of complication, and prevention of long-term sequelae. Now, this is the thing given in our national guideline. Protection of compromised skin and mucous membrane, I have said it is very important. In skin rash, you can apply some simple clean the lesions with simple antiseptic. You can apply mupirocin or fusidic acid. You can cover the extensive skin lesion with light dressing, and do not touch or scratch the lesion. And in case of secondary infection, only in such cases you can use an antibiotic. Genital ulcer, you can advise sitz bath. Oral ulcer, you can advise warm saline gargle or oral topical anti-inflammatory gel. Conjunctivitis is usually need not have any intervention. It is usually self-limiting, but sometimes, rarely, it can affect the cornea and lead to blindness. So in such cases, ophthalmologist can be consulted. Now, rehydration therapy, because many a times due to poor appetite, nausea, vomiting, diarrhea, etc., the patient may be dehydrated. So rehydration is very important. Oral fluids and ORS should be given. IV fluid, if indicated, should be given, and encourage the patient to take nutritious and adequate diet. Symptom elevation, all of you will know, this is a fever, tepid sponging, paracetamol. Itching, pruritus, you can apply topical calamine or antihistamine. Nausea and vomiting, consider giving antihistaminics. And headache, paracetamol and severe adequate hydration. Now coming to specific treatment. Even though these are there, it is not available to us as of now, but we should know, we should be acquainted with these. These are drugs that are initially accepted for smallpox, but it is found to be useful to some extent in monkeypox also. The first drug, tecovirimat, is the drug that is licensed for monkeypox by European Medical Agency in 2022. In 2018, it was accepted for smallpox, and now in 2022, it has been licensed as an antiviral agent for monkeypox. The dose is 600 milligram BD per orally for 14 days. Another drug is bimcidovir, or which is said to be useful in monkeypox to some extent. 200 milligram weekly for 2 days. Only 2 days doses is needed. And the cidofovir, which we use, can also be used, but there are some adverse effects for that, so usually not recommended. Now coming to vaccines, as I have already told, smallpox vaccine offer almost 85% protection for monkeypox. And this two vaccines, both the vaccines are newly developed. Old smallpox vaccine is not available now, but these are the newly developed smallpox vaccines. One is ACAM 2000 and another one is Jynneos. And ACAM 2000 is the first thing that is developed. It is a replication competent vaccinia virus, which is single dose multiple percutaneous puncture technique. So that is the similar to old technique of your smallpox vaccine, but since it is a replication competent virus, vaccinia virus, there are chances of some adverse effect, including cardiac adverse effect. So the second one, Jynneos, is the one which is now usually recommended. It also is derived for smallpox only, but it is very effective against monkeypox, replication deficient modified vaccinia virus, And it is as in many vaccines, it is subcutaneous, 2 doses, 28 days apart. And since it is a replication deficient, derived from replication deficient virus, it has fewer adverse effects. But as a whole, we can say that there is no fully proven and available treatment as of now, specific treatment as of now, even though it is a self-limiting disease and you can have symptomatic treatment, but direct antiviral vaccines are not fully proven and available now. And for purpose of controlling an outbreak, you may use smallpox vaccines, as I have mentioned, and if antivirals are available, it can be used, and vaccinia immunoglobulin can also be used if there is an exposure, a close exposure. Now coming to last few slides, which is the recommendations that every hospital or health authorities should do. Healthcare facility should have a high index of suspicion in patients who have otherwise unexplained rash. So unexplained rash, any patient who has traveled in last 21 days to a country that has confirmed or suspected case of monkeypox, or who has directly reported contact with a patient with a suspected or confirmed monkeypox. And all suspected cases is to be isolated as designed healthcare facilities until all the lesions have resolved and a fresh layer of skin is formed, or until the treating physician decides to end the isolation. All such patients should be reported to district surveillance officer of IDSP, and all infection control practices that we have followed during the COVID time should be followed by treating such patients. You should use appropriate PPE in treating the patient. Laboratory samples consisting of fluid from vesicles, blood, sputum, etc. should be sent to NIV Pune, because it is the only area where you have the facility for testing, PCR testing for monkeypox. In case of suspected cases, and in case of positive case, you should immediately start contact tracing like that we have done in COVID patients initially, and then identify the contacts of the patient for last 21 days, and high risk contacts should be isolated from others. So that is in nutshell.
Thank you, Dr. Sarin, for the excellent
Effectively, 2 days before the 2 days before the
fever usually can start in first 1 day.
and after scanning അത് നമ്മള് ഇപ്പൊ കണ്ട 2 കേസുകൾ ദുബായിലാണ്. അവിടെ ദുബായിയുടെ സിംഗപ്പൂർ
the government of Kerala released a paper telling that like other viral diseases, there is not treatment for malaria. As a government doctor, inform the authorities that majority of viral diseases are having sufficient treatment, including other mentioned. I don't know why, whether it is influenced by the Irish people or others, I don't know. I have had a discussion with Dr. Ramesh. So this issue should be considered as a community issue, because So why receiving this kind of disease, other people will come, they don't have treatment, we do have treatment. So I think that should be explained properly to the government officials, including the administrators.
This is why
already in such a process.
Sir has correctly said, many of the viral diseases which is severe, like HIV or hepatitis, C, B, cytomegalovirus. No, now one thing is that this antiviral has been recently only come into market, and mainly even not even in market. Actually, it is only given by the government authorities over there. The first. അല്ല അതാണ് ഞാൻ അതാണ് പറഞ്ഞു വരുന്നത്. അത് പറഞ്ഞു സാറ് ചോദിച്ചുകൊണ്ടതിന്റെ ഉത്തരം പറഞ്ഞു. അപ്പൊ അതിൽ ഞാനത് ഡിപ്പെൻഡ് ചെയ്യുന്നതല്ല. പിന്നെ ഞാൻ പറയുന്നത് ഇത് ഫോർമുലേറ്റ് ചെയ്യുന്നത് വളരെ ഒരു ഇതാണ്. സാറ് പറയുന്ന പോലെ തെറ്റിദ്ധാരണ ഉണ്ടാക്കാനും അത് മറ്റുള്ളവർ ദുരുപയോഗം ചെയ്യാനും ഉള്ള സാധ്യതയുള്ള ഇത് തന്നെയാണ്. Majority of the viral disease need not have ചികിത്സ സ്പെസിഫിക് ആന്റിവൈറൽ എന്ന് പറയുന്നത് ശരിയാണ്. പക്ഷെ ചികിത്സ ഇല്ലാന്നുള്ളത് തെറ്റാണ്. അതാണ് അത് ശരി. ആ ആസ്പെക്ട് ശരിയാണ് ഞാൻ പറയുന്നത്. അതെ അതെ സ്പെസിഫിക് ആന്റിവൈറൽ ഇല്ല വേണമെങ്കിൽ പറയാമായിരുന്നു. അതെ അതെ ഇല്ല, ഇത് ഇപ്പോൾ ഉള്ള അവൈലബിൾ എന്നാലും 70 മുതൽ ഉള്ള ഒരു ഡിസീസ് ആണെങ്കിലും എല്ലാ ആസ്പെക്ടും അതിന്റെ ഇതുവരെ കൃത്യമായിട്ട് അറിയില്ല. ഇതുവരെയുള്ള എവിഡൻസ് വെച്ചിട്ട് ബ്ലഡ് എന്നുള്ള ഒരു ഇത് സെമൻ വഴിയിലല്ലോ സെമനിൽ DNA കണ്ടുപിടിച്ചില്ലെന്ന് പറയുന്നത്. പക്ഷെ അത് ഇൻഫെക്റ്റീവ് ആണോ എന്നുള്ളത് രീതിയിൽ ഇതുവരെ തെളിയിച്ചിട്ടില്ല. ഈ ലീസൺ ഓർ കാവിറ്റിയിലും ജെനിറ്റേരിയയിലൊക്കെ കാണാം. ഇപ്പൊ സെക്ഷൽ കോണ്ടാക്ട് ആ രീതിയിൽ തന്നെ ഉണ്ടാകാം. പക്ഷെ അതാണ് ഇവിടെ ക്ലാസിക്കൽ സെൻസിൽ ഒരു HIV പകരുന്ന പോലെ ഇത് പകരുമോ എന്നുള്ളത് ഇതുവരെ തെളിയിക്കപ്പെട്ടു. പക്ഷെ മെൻ ഹാവിംഗ് സെക്സ് വിത്ത് മെന്നിൽ അങ്ങനെയുള്ള ഹോസ്പിറ്റൽ ആൾക്കാർക്ക് ഇത് ക്ലസ്റ്റേഴ്സ് ഉണ്ടായിരുന്നു. എസ്പെഷ്യലി UK ക്ലസ്റ്റേഴ്സ് ഉണ്ടായിരുന്നു. റെസ്പിറേറ്ററി സിംറ്റം അവർ പറയുന്നത് ഓറൽ അൾസറൊക്കെ ഉള്ളവർക്കാണ് കൂടുതൽ വരാൻ സാധ്യത. ചില ഡ്രോപ്ലെറ്റ് ആണ് പറയുന്നത്. ഡ്രോപ്ലെറ്റ് അതായത് ഞാൻ കുറെ സ്ഥലത്ത് റെഫർ ചെയ്തു. ചിലര് 6 പറയുന്നുണ്ട്, ചിലര് 3 പറയുന്നുണ്ട്. എന്നാലും പ്രൊലോങ്ഡ് കോണ്ടാക്ട് Chickenpox, monkeypox also majority is self-limiting. ഈ കോംഗോ ബേസിൻ ഇതിന് up to 10% പിന്നെ മോർട്ടാലിറ്റി പറയുന്നുണ്ട്. ഇപ്പൊ പകരുന്നത് വെസ്റ്റ് ഏഷ്യൻ സ്ട്രെയിൻ ആയിട്ടാണ് പറയുന്നത്. അതിന് 3 മാക്സിമം 6% വരെയൊക്കെ 3 ആണ് ഓൺ ആൻ ആവറേജ് പറയുന്നത്. 0 to 3% ആണ്. ഈ ഔട്ട്ബ്രേക്കിൽ 2022 ഓൾമോസ്റ്റ് 3500 ആൾക്കാർക്ക് ഇൻഫെക്റ്റഡ് ആയ ഒരാൾ മാത്രം ലഭ്യമാണ്. അപ്പോൾ മോർട്ടാലിറ്റി കുറവാണ്. പക്ഷെ ഇന്ന് കോംപ്രമൈസ്ഡ് ആയിട്ടുള്ളത് പ്രഗ്നന്റ് ലേഡീസ്, പിന്നെ സ്മോൾ പോക്സ് വാക്സിൻ എടുക്കാത്ത ഇങ്ങനെയുള്ള ഡയബറ്റീസ് പോലുള്ള ആൾക്കാരെ, അങ്ങനെയുള്ളവർക്ക് സിവിയർ ഡിസീസ് വരികയും ഡെത്ത് ഈ ലെവൽ വരെ ഉണ്ടാകാനും സാധിക്കും.
ചോദിക്കുന്നത് ഹൈപ്പിന്റെ ആവശ്യമുണ്ടോ? ഹൈപ്പല്ലേ ചിക്കൻ ബോക്സ് പോലെ
പിന്നെ കോങ്കോയിലുള്ള സ്റ്റെറിലൈസിംഗ് ആയിരിക്കാം. ഞാൻ പറഞ്ഞ പോലെ മോർട്ടാലിറ്റിക്കും പല കാരണങ്ങളും സാർ പറയുന്ന പോലെ സോഷ്യൽ ഇൻഡിക്കേറ്റേഴ്സ് ഇമ്പോർട്ടന്റ് ആണ്, ട്രീറ്റ്മെന്റിന്റെ ഇത് ഇമ്പോർട്ടന്റ് ആണ്. പക്ഷെ സ്ട്രെയിനിന് തന്നെ ഈ ഡിഫറൻസ് ഉണ്ടെന്ന് പറയപ്പെടുന്നു. സിംറ്റമാറ്റിക് ആക്ച്വലി പേഷ്യന്റ് സ്റ്റേബിൾ ആണ്. വലിയ അങ്ങനെ ഒരു നമ്മൾ ഈ സാധാരണ ഈ ടോപ്പിക്കൽ ഇതും അങ്ങനെയൊക്കെ കൊടുക്കും. ബോഡിക്ക് അധികം ഇല്ല സാർ, മെയിൻലി അല്ല ബോഡിയിൽ ഉണ്ട് ഫ്രങ്കിൽ അധികം കാണൂല എന്ന് പറഞ്ഞിട്ട് ഇയാൾക്ക് ബോഡിയിൽ കുറച്ചുണ്ട്, പക്ഷെ ഫേസിലാണ് ഏറ്റവും കൂടുതൽ. പിന്നെ തൈസ്, പിന്നെ ഫോറാം, അങ്ങനെയൊക്കെയാണ്. സ്കാൽപ്പ് അവരുടേത് പിന്നെ അങ്ങനെ ഡെഫിനറ്റ്ലി കിട്ടും. പിന്നെ മറ്റേ കോൺട്രിബ്യൂട്ട് ഇനീഷ്യൽ അതാണ് ഇനീഷ്യൽ സ്റ്റേറ്റിൽ സിംഗിൾ ലീഷനോ അല്ലെ 1-2 ലീഷൻ ഇങ്ങനത്തെ എല്ലാം ഇതാവാം. ഈവൻ മറ്റ് STDs ഇപ്പൊ നമ്മൾ പിനൈൽ അൾസർ ആണെങ്കിൽ പിന്നെ നമുക്ക് പറയുന്നത് ഷാൻഗ്രോയിഡ് ഇതൊക്കെ DD ആയിട്ട് വരാം. അപ്പോ പിന്നെ 1-2 ലീഷൻ വരുമ്പോൾ നമുക്ക് ഈ DD ഒക്കെ വരാം. പക്ഷെ വിത്തിൻ ഒരു 1-2 ദിവസം കൊണ്ട് തന്നെ ഇത് പലയിടത്തുമായിട്ട് വരും. ഉദാഹരണം മോണോമോർഫിക് ആണ് മെജോറിറ്റി ആയിട്ട് പറയുന്നത്. നമ്മളെ പേഷ്യൻസിനെ അല്ലെങ്കിലും ഒരുമിച്ച് ആണ് ഇത് വരികയും അതിന്റെ ഒരു ട്രാൻസ്ഫോർമേഷൻ നടത്തുന്നതായിട്ടാണ് പറയുന്നത്. അപ്പൊ അത് ഒക്കെ DD ആയിട്ട് വരാം. ജെനിറ്റൽ ലീഷൻ വരുമ്പോ ഇതൊക്കെ DD ആയിട്ട്, പക്ഷെ അത് മറ്റേത് അങ്ങനെ ഉണ്ടാകും. ഈ മോളസ്കത്തിലില്ലല്ലോ, എപ്പോഴും പറ്റില്ല. പക്ഷെ ഷാൻഗ്രോയിഡിന് ഒക്കെ വരാം. ഷാൻഗ്രോയിഡിന് വരാം. ഷാൻഗ്രോയിഡിൽ അത് മാത്രമായിരുന്നു ഷാൻഗ്രോയിഡ്. പക്ഷെ നമുക്ക് അപ്പോഴേക്കും ഫേസിലൊക്കെ വരും. Then we can within 1 or 2 days we can have it.
Santosh, anything to add? Okay. Next is vote of thanks for secretary.
On behalf of the Kannur IMA, I express our sincere thanks to Dr. Sarin for his excellent and highly informative talk on Monkey Pox. Thank you, Doctor. Also, I thank all members of the Kannur IMA for attending this training. Thank you.